So in terms of the safety of FGFR inhibitors as a whole, what we know is that the majority of the adverse events that were seen in the FIGHT 202 study, in the initial work with infigratinib, and that of course are of interest in, say, the PROOF trial, are what we call class effects. So these are side effects that we know come from targeting the FGFR pathway. They are very different than the types of side effects that we see with standard chemotherapy like gemcitabine and cisplatin. We are not as worried about cytopenias and knocking out people's immune systems. But there are side effects that are really important in terms of quality of life for patients, and I think have learned well how to proactively manage these side effects so that we can hopefully maintain quality of life for patients. Those side effects includes things like dry eyes, dry skin, dry mouth, so kind of dry mucous membranes, as well as some alopecia, hair loss. There's some interesting nail changes that happen that can be quite painful for patients. And then some of the FGFR inhibitors cause diarrhea, some more than others. And then, of course, the hyperphosphatemia, so the elevated phosphorus levels in the blood, for which some patients require the use of phosphate binders and such to ensure that their levels do not get too high. There are some ophthalmologic concerns in terms of both just vision changes. Patients' eyelashes grow a lot, and they tend to grow inward and can cause kind of abrasions, frankly, of the cornea. And then more serious ocular concerns, which frankly have been rare so far in the FGFR story thus far. But these are all things that are going to be of great interest as we put more patients on these frontline types of studies. With the myriad of FGFR inhibitors that we have now, I would say that the majority of the side effects that we see are similar across the board. I have not seen dramatic differences, for instance, in terms of the rate of hyperphosphatemia. Interestingly, in the FIGHT 202 study, they had a fair amount of hypophosphatemia, but I think the thought there was that that's because the patient's labs were being aggressively followed, and then their phosphorus levels were being aggressively managed, and so they ended up with lower phosphorus levels. So I don't think that those things are dramatically different. I think that the mucous membrane and skin changes also have been relatively equal across the board in terms of the FGFR inhibitors. There's perhaps an indication that there is slightly more diarrhea with pemigatinib, for instance, compared to the data that we have with infigratinib. And there's a lot of scientific thought going into whether that's because infigratinib is a little bit more of a specific FGFR inhibitor and does not hit the FGFR4 receptor as much as pemigatinib does. But the numbers are small, and I think, again, as we do larger studies and follow this a little bit more robustly, we'll have a better sense of that. But that, I think, has really been the only difference, if you want to call it that has stood out, is the diarrhea. Yeah, so the FGFR 1 through 3 receptors across the different FGFR inhibitors, there seems to be a similar amount of specificity for those 3 receptors, and they seem to play a large role in the phosphorus excretion and homeostasis, as well as some of the changes that are seen, for instance, in the skin and mucous membranes. And then the FGFR4 is really where, like I said, we see a little bit of a difference in terms of the FGFR inhibitors' level of specificity for binding FGFR4 versus the others. And that perhaps may play a role in some of the differences that we're seeing in toxicity. But this is so far hypothetical. I think we need a little bit more robust data to know that for sure. But when you look at the idea of how these drugs bind each of these receptors, there is clear differences there between the FGFR4 versus the 1 through 3, for instance, in infigratinib versus, say, pemigatinib.